So thank you everyone for coming. Today's is the fourth webinar session or research presentation on the MRL Diagnose and Treat Your Research Problem platform. The presenter will be Dr. Dansure. She's going to present a thesis proposal on neonatal birth outcomes of teenage pregnancy and associated factors in selected hospitals of Addis Ababa. And this is a thesis for partial fulfillment of a master's program. She's a medical doctor and studying her Master of Public Health at Yekaitas Hospital Medical College. Our guest reviewer will be Professor Delayo. Professor Delayo is a professor of fetal-maternal medicine subspecialty in obstetrics and gynecology. And he is currently working at St. Paul Hospital Medical College. He also has a Master of Public Health and Masters in Clinical Trial. He is one of my personal role model in clinical research because he's a good clinician, working on a daily basis as a clinician, but also a very good researcher. There is a lot we all can learn from him, and we're glad to have you here today. His profile is very long to read, very difficult, but it's okay because I'm sure you all know him. So for the in-house review, I will be the one reviewing the article. My name is Tigist. I'm a medical doctor and public health specialist and the founder and general manager of Medical Research Lounge. And the rest of the review will be contributed by the audience, and we will accept all of your questions. You can drop your questions on the chat box and we'll address them at the end. So I'll give the floor for Dr. Dansure. You can start your presentation, and if there is any comment or suggestion, you can drop it on the chat box. Thank you.
Okay, thank you very much for having me. My title is Neonatal Birth Outcomes and Associated Factors of Teenage Pregnancy in Selected Public Hospitals in Addis Ababa. These are my outlines. WHO classifies people aged 10 to 19 as adolescents, 13 to 19 as teenagers, and 15 to 24 age as youth. Respectively, there might be some overlap here. Ethiopia has one of the world's highest rates of adolescent pregnancy, which is a major public health concern. Teenage pregnancies are affected by social norms, beliefs, and economic barriers and struggles. Population of the world is estimated to be growing by around 67 million people. That is 67 million children. So 21 million pregnancies are from adolescents and others, and half of these are unintended. Ethiopia is one of the African countries where the highest teenage pregnancies are being recorded. Only 7 nations account for about half of all teenage births. One study shows that Ethiopia is one of the 7 countries where half of all teenage births are seen. EDHS 2016 finding shows that the prevalence of teenage pregnancy is around 13%. The median age of women at first sexual intercourse is now estimated to be 16.6 years. And currently, about 17% of adolescents in Ethiopia are married. So this study tries to find out the neonatal outcomes of teenage mothers and their associated factors. So what's the problem? What's the significance of this study? It's to identify and localize the determinant factors associated with outcomes. And this study will provide relevant information for policymakers or NGOs or anyone interested to design appropriate strategies to prevent adolescent pregnancy and reduce the adverse birth outcomes. So this is my conceptual framework. And as we can see, cultural factors, maternal conditions like age, marital status, contraception use, education level, socioeconomic factors, and this all affects neonatal births in teenage mothers. This is individual level. When we see as a country level policies, there are different policies and regulations. So I'll try to see how these policies are, how they affect teenage mothers. These are my objectives. My general objective, as I've mentioned earlier, is to assess neonatal outcomes and associated factors in teenage pregnancy in selected public hospitals. Specific objectives are as follows: to assess neonatal outcomes and to identify the associated factors. Okay, my study area. The study will be conducted in all public hospitals under Addis Ababa City Administration. There are 6 hospitals, namely Yakarta Asrol, proportional sample size allocation was made to each hospital based on their previous annual count flow. This will be seen on this table. So based on the previous annual teenage pregnancy flow, I've calculated the sample sizes to different hospitals. Okay, my study design is this cross-sectional study. It's facility-based. My source population, all mothers who gave birth in their respected hospitals are the source, and specifically teenage mothers will be studied. Exclusion criteria, charts of mothers with pre-existing medical diseases, as this might influence the neonatal outcome, are not included. Multiparous mothers are not included. Incomplete cards or severely ill patients who are unable to communicate are not included. Apart from this, all teenage mothers who give birth at 28 weeks or above are included in the study if they are found in that specific area and time. Okay, this is how I determined my sample size. It's the p-value is found from a previous study conducted in East Kojam. The highest number of sample size was found to be based on from a neonatal birth outcome and labor date. So I used this with the confidence interval of 95%, margin error 5%, using a single population proportion. The value was to 201. As you can see, the plan is to divide this sample size into 6 different hospitals. The highest would be in Gandhi, and the Catastrophic Hospital will be next. Zaudis will be next. So this is how it's calculated. I'll be using a face-to-face interview and chart review using a structured questionnaire by trained professionals in all the 6 hospitals, 2 BSc midwifery professionals or 2 diploma midwifery professionals were oriented by the principal investigator about the purpose of the study, how to collect the data, as well as how to fill the questionnaire properly. Interviews were made using structured questionnaire prepared in English, then translated to Amharic. The questionnaire will only be held after the mother's condition was stabilized. Convenience non-probable sampling technique will be used. From the log sheet of the delivery ward, teenage mothers will be counted. Their card number and bed number will be referred and included in the study if they meet the criteria until the sample size is reached. These are my dependent and independent variables. Neonatal outcomes, since my goal is to study neonatal outcomes, these are, I'm going to these are I'll be taking 4 different outcomes: alive date, gestational age, birth weight, and APGAR score. The APGAR score will be 15 minutes. Birth weight will be below 2,500 grams and above 2,500 grams. I have categorized them like this. My gestational age will be below 37 weeks and above 37 weeks, and alive date. My independent variables: maternal, socio-demographic characteristics, age, parity, marital status, contraception use, educational level, siblings who are sexually active, and teenagers who come from broken family. My maternal medical and maternal medical condition will also be included. These are number of NC visits, any chronic illnesses, HIV status, and iron supplements. I'll be using for my data analysis procedure, structured questionnaire will be used. Data will be checked for completeness, edited and coded using epinfo, then transferred for analysis to species. Descriptive statistics will be used to know frequency, percentile, and mean of different variables. And I'll be using logistic regression to analyze the data, to get into the detail. By various logistic regression will be done to identify relative prediction level of each of the independent variables, with the dependent variable and variables having p-value less than 0.2 were considered to have an association, and this will be transferred to the multivariate logistic regression analysis to identify the relative prediction levels for the independent variables. And the variables having p-value less than or equal to 0.05 will be considered statistically significant. The data will be collected by administering questionnaire. The questionnaire have been prepared after reviewing several related research articles and modified into local context. The questionnaire has mainly 3 parts: socio-demographic characteristics, reproductive and obstetric characteristics, and neonatal outcomes. Ethical clearance letter will be obtained from Hospital. A letter will be sent to Ethical Clearance Committee under the City Administration Bureau, which in turn letters will be sent to to the 6 respective hospitals. Confidentiality will be kept by avoiding the client's name. Data won't be shared to any other third person except for the advisor before enrolling any of the eligible study participants. Purpose, benefits, and confidential nature of the study will be described and discussed for each participant. Only those who have consented and agreed will take part in the study. And this is my work plan summary, my budgets. Okay, thank you very much.
Thank you very much, Dr. Nasre, for the nice and timely presentation. Now we can start with the suggestion. We'll start with Professor Delayo. Please display the slides on which he's going to comment on so that we can read them. So over to you, Professor Delayo.
Okay, thank you, Dr. Tigist. Can you hear me?
Yes, we can hear you.
Okay, thank you. Thank you, Dr. Tigist, and also Dr. Dansore for presenting the presentation. And I have reviewed your proposal, and my comments would be based on what I've reviewed on the proposal. There are few changes you have added now, so that's good that they're added, but my comments is based on the one which I've reviewed. So understand it with that context. So you have identified a very good research area. Teenage pregnancy is one of the general adolescent reproductive health is now it is one of the priority of our Ministry of Health, and because it is the adolescents are considered to be a window of opportunity if we can work much on their reproductive health. It's going to change tomorrow's generation. So this teenage pregnancy is part of that. So thank you for selecting this topic. So I have some comments on your proposal. So the title, Neonatal Birth Outcomes of Teenage Pregnancy and Associated Factors in Selected Hospitals of Addis Ababa. Yeah, so from the content also in the body, you can see that what we are going to study is the immediate birth outcome. So it's good you have mentioned the term birth outcomes, but different background in the other parts should be consistent with the title and what you are planning to do later on. I've seen some sentence in the background, for example, the research aims to investigate fetal outcomes among teen mothers in public hospitals and so on. So if you are going to include fetal outcomes and others, the terminology rather than neonatal birth outcome might need to be perinatal outcome, but the other part of the proposal shows that actually what you are doing is neonatal immediate birth outcome. So you should underline some of the statements in the literature review background and so on to go with that. And in the literature review, and also later on I'll come to it in the independent variable selection, you have dwelled much on predisposing factors for teenage pregnancy rather than actual neonatal outcome. Okay, like for example, you have some good literature review on how contraception use or the sexual activity of their siblings, or cultural factors like abduction, child wedding, or sexual experience before the age of 50 and so on, how they affect the or predispose to teenage pregnancy. But you should be more focused. This one would be relevant if you were to study risk factors or predisposing factors for teenage pregnancy. But now you are going to study the neonatal immediate birth outcome of teenage pregnancy. So this discussion, these things, you might not need to dwell in detail in the literature review, but even worse than that is that you have put them also as part of the independent variable in the independent variables, right? So, but they are something which, you know, scientifically are not plausible explanation for any neonatal positive or adverse outcome. Like, for example, sexual experience of or sexual activity of their siblings or something like that would not be plausible. So reduce them as much as possible from the literature review, and also you may not need to include as part of the independent variables. And the other one is the significance of the significance of the study. You have put that findings from the study will provide relevant information to policymakers and NGOs in designing appropriate strategies to prevent adolescent pregnancy. Okay, so this study may show us that adverse neonatal outcomes are very common in or not different from the other general population, but it will not inform us or give us a clue for policymakers on, you know, how to reduce teenage pregnancy or adolescent pregnancy, because the way it is designed, it's objective later on, and also the questionnaires and so on are more of for neonatal outcome rather than telling us what makes adolescent pregnancy more prevalent and what strategies needs to be taken to reduce it. So you should amend it accordingly, make it more aligned again to your study. The part which says also gap analysis, it doesn't do any gap analysis. You mentioned one study in Gojam and one study in the USA, which have showed higher incidence or higher odds of low birth weight and preterm births among teenage pregnancy. And then you dwelt on the different factors which affect the predisposition for teenage pregnancy, like resident education and so on, and you just closed it. You haven't shown us the topic, the subtitle is gap analysis, but you haven't really shown us the evidence gap and which you want to fill. So I think you should work on that section also a bit. You should refine it. And the other thing is, it's not clear why you want to, why you selected hospitals, or why don't you do it, for example, if someone asks you, why don't you do it in health centers, which might be more representative of the population as compared to hospitals where you have selected referred individuals. Is it to get because they are high volume, are thinking that you can achieve your sample size of desired sample size, or why did you select hospitals versus health centers? And also the way you made it, the selection of the hospitals, you made it more of administrative rather than scientific. Okay, you said hospitals under the Addis Ababa Regional Health Bureau. Okay, so one might challenge you, rather than doing that, there are a number of hospitals in Addis. There might be public, private, but there might be, if you think that there might be challenges with the private one, if you want to include only the public hospitals, you can take all the public hospitals or randomly select the public hospitals, okay, rather than making it more administrative. Okay, so if one asks you why you dropped Black Line Hospital or Alert Hospital or St. Peter or St. Paul, if you say that it is because they are federal rather than regional, that might not give like sense. So an ideal would have been to list all the public hospitals and then randomly with some random method selecting the hospitals you want to work on. Again, the conceptual framework, it doesn't more reflect about neonatal outcomes, but more again the factors which determine the teenage pregnancy itself, rather than the neonatal outcome. So you should revise it to reflect more of your study objective. So the other one is the methods, the eligibility criteria, the inclusion criteria. You have put all teenage mothers aged 13 to 19 who gave birth at 28 weeks of gestation or above. But I'm not sure why you choose 13 to 19. It's better to make it 10 to 19, or to align with WHO and definition, and also because there might be some who are practically less than 30 but get a WHO report which was released recently in June 2023. So in that one, they have specifically, it was describing about childbirth among girls aged 10 to 14, between 10 to 14, and the estimate in sub-Saharan Africa is 1.5 per 1,000 women. Okay, so there is no reason to skip the miss one between 10 to 13. Okay, so those are rare. There are some number of teenage pregnancies in that age group. So better to make it wider and inclusive and aligned with standard definitions of adolescent or teenage pregnancy. And these exclusion criteria, you have excluded teenage mothers who had known medical disorder for pregnancy or who was twin pregnancy and so on. Okay, I'm not sure why you did this, because if your study was designed to compare the neonatal outcome between teenage pregnancies and their adult counterparts, you might want only to see the effect of being a teenage pregnancy, and you might want to avoid the nuisance from other factors like these medical disorders or being multiple pregnant and so on. But you are not doing that. You just want to see the neonatal outcome among these teenage pregnant women. So you may not need to exclude them. You can include them. Okay. So that's one comment. Okay, and when you go to the questionnaire, and also if you see the questionnaire, you have included whether it is a single-term pregnancy, multiple pregnancy, and so on. Okay, so it doesn't go with the exclusion criteria as a question, the content of the questionnaire, but I think it's good to keep what's in the questionnaire and not to exclude them if you are going to go outcome of teenage pregnancies in general. The other thing is sample size calculation. You have used a single proportion of 13.8. You said from a Gojam study done in Gojam, but that study was not referenced. So I wanted to actually see what that proportion is. You said days. If it is stillbirths or is it stillbirths plus immediate early neonatal days, it's not clear. And that 13.8% is a high number. I wanted to check what it is specifically, but you haven't referenced that study, or it's difficult to get it. So whenever you use some study as to take some parameters for your sample size calculation, that they should be referenced. And this sample size, for the first objective, it because your main dependent variables are like vital status, whether the newborn is alive or dead, if it is a preterm birth, low birth weight, and so on. But for that first objective, because you have these multiple variables, you may need to calculate sample size ideally for each of them. You can put it in a table, for vital status, if the 13.8% is one you get from the reference, what is the prevalence of low birth weight, what's the prevalence of preterm birth, and so on. And based on that, you can calculate sample size, and you can select the biggest one to be to have good sample size, which you can reasonably determine the proportion of those outcomes. And for the second objective, you might need to use two proportion formula, because you are planning to do some inferential statistics, and they have you'll have multiple categories in those the independent variables. So the one you calculated with one of the proportions, even among the proportions, just one of the proportions might not be enough or well powered to answer for you to answer the other questions which are in the more inferential objective. So you may need to calculate also sample size for at least for the main selected independent variables. It may not be able to do for all, and it might not be necessary, but for the selected salient ones, you may need to do a sample size calculation. You can put it again in tables and select the largest sample size. And also this sample size, again, it's related with that. You plan to conduct the study between May 20 to June 23. That's a 2 months period, and you have some sample size. Are you sure that you can achieve sample size given of teenage pregnancy in those 2 months? And for that, my question was, have you had a sort of a preliminary data of the hospitals, past 6 months or a year proportion of teenage pregnancies to ensure that this is a reasonable period? You have put a table about that one during your presentation. That's a good thing, and you can use that one also to estimate and make sure that proposed time is enough to get adequate sample size. So that's an addition which you made in the presentation, and it is a good one. Again, sample size, one minor comment for your knowledge also is when you calculate the final sample size considering the non-response rate, you just don't add 10%. Okay, so it seems like you have calculated 183 as sample size, but and you have added 10% of it, that is 18, and you have come up with 201. Okay, so that's not the way you calculate when you have non-response rate. What you should do is with this the formula is a calculated sample size divided by 1 minus the non-response rate. That means 1 minus 0.1, or going to be 1 over 1 over 0.9. So as to calculate that one quickly, but anyways, it's not 201. It might be a bit different from that one. Okay, if you see, for example, from 201, if you have a 10% response rate, you are going to reduce around 20, which would be 180. So 81, or okay, so which is not 183. But if you use the previous formula, it would exactly come 183. It's a common error, but you can amend that one. And related with the sampling, again, you have mentioned this one in your presentation here, that you are going to use a convenience sampling, a sort of a take-all sample size, to take all till you fulfill the sample size. But that's good that you have mentioned the sampling method now. But in the proposal, there is no sampling method which was mentioned. So now we have mentioned that, and how you are going to allocate also the proportion to the hospitals was also my question. Now we have that preliminary number of deliveries in each hospital. I think you'll use that one, but you can include that in the protocol, and it shows the depths you have gone in preparing the proposal, and based on the previous table you used, you can show or make a table of how you are going to distribute the calculated sample size among the different hospitals. So collection methods and procedures. This is again this minor comment, but it should be amended to make it up to the standard. All what you have written there is in past tense, like data were collected from mothers, hospital-based data collection was made, and so this will be a future tense as we are having now. We are writing a proposal, so use those is minor, it will make it unacceptable. So in the protocol. So in the next section is the variables. So some of them, like alive or dead, you can call it vital status. We call it like that in many studies. So you should mention here or in the operational definition up to when you are going to observe the newborn. Okay, because if you are going to observe, for example, immediately after birth within let's say 1 hour and so on. The outcomes there will be different if we are going to observe the newborn for a day till discharge or something like that. Okay, so should be very specific to standardize things. Otherwise, based on the timing of that definition or criteria you are going to use, numbers will change. Okay, so if you are taking 24 hours, it might be more days. If you are taking immediate neonatal outcome immediately after delivery and so on, it will be a different number. So you should standardize it, that vital status. When are you going to make the observation, and that should be clearly put. The other thing is the next dependent variable is the gestational age. So that one in many studies, this is a very challenging. Many studies of preterm birth or prevalence or determinants of preterm birth. The gestational age, how is to be determined is okay, because that again may differ based on how you determine it, how accurate it is. Are you going to use just the LMP or the ultrasound, or are you going to use algorithms if she has a good early ultrasound, if we never, like, let's say, first trimester, and disregard the LMP, or which one is going to be used for those with unknown gestational age? Are you going to use neonatal assessment like Ballard score and so on? Unless you go into clear definitions, the prevalence of preterm birth or you are going to determine would be it's a standard to have a clear definition of how gestational age is going to be determined to later on have a good reporting and showing comparability with others, then for any aggregations which might be made in the future. And again, as there are some potential dependent variables which you haven't included in the protocol. I think one of them, like I can't hear the Apgar score, you have included it now, but you should include them in the protocol, like the NICU admission, because you have, it seems like you are going to collect that from the questionnaire. I can see that neonatal conditions like PNA, perinatal asphyxia, RDS, and so on, they're included in the questionnaire. So if you collect them, you can put them as a dependent variables also. They are worth seeing because for various reasons, there might be good scientific evidence that they might be higher in those with teenage pregnancy. So in the independent variables, okay, this one goes with the initial comment that I have made. Some are not plausible to be independent variables for neonatal outcomes, so you might need to remove them, like the one which says siblings who have who are sexually active or contraception use, okay, and so on. You might need to be selective in removing them because they are not unlikely to be related with any neonatal outcome. The other concern I have is in some of the independent variables, when you see them logically, they might be very uniform or like, let's say, the parity. Okay, almost all of them are likely to be nulliparous, okay, or gravid because of their age nature. So as independent variable, you might not be able to make any sort of statistical analysis using the, again, with HIV status. This age is said to be the window period where you have a very negligible prevalence of HIV, okay, and if almost 100% of them are nulliparous or HIV negative, or the same goes with chronic illness, they are this age, because they are a very young age, the prevalence of most chronic illness is negligible. So, be careful later on. This might not be like something which you can make some sort of reasonable comparison among the subcategories within them. The other thing is operational definitional part. You have put some good definitions like adverse neonatal outcome, severe neonatal conditions. Okay, so you have even used some references to you have taken. So this kind of definitions or outcomes, we call them the composite outcomes. They are good because each of these variables within them might be rare, and it might be difficult to make any statistical analysis because of their small number. But when you make adverse neonatal outcome or such kind of composite definitions, they add up, and you might get a reasonable number to make to play with the statistics. So you have put them, it's good, but if you put them here, you should show that you are going to use them by putting them in the as part of the dependent variables. Okay. So again, for the preterm births, you may need to put an operational definition. You may need to put it as an operational definition how the gestational age is going to be determined. It needs to be operationalized. In the teenage pregnancy, you have put it up, somewhere above, but you can put also for your study purpose how it's the operational definition. It's good to include that in the operational definition on top of what we have put in the other part. So in the data analysis, it's always good to have a specific and detailed portion of analysis plan, okay, with some dummy tables. This is especially important for your study because for me it looks very vague, like you are going to have like a number of independent variables, sorry, dependent variables, and you have also independent variables, which some of them have the previous concern. Okay, so if you put some dummy tables, how you are going to do the 2x2 tables and the the regressions you have mentioned and so on. By looking at the tables, you can have some sense of clear idea of how you are going to do the analysis, and also if there are some expected challenges and so on, it may make it more apparent. So I strongly urge you to have a detailed statistic analysis plan and those dummy tables, and look at them and just anticipate. It's what they call starting with having the beginning with having the end in mind, so that you didn't discover the challenges later on after everything is collected and so on. So you can work on the analysis plan very well. It will help you very much for your proposal. It's specifically, it looks like to be very important. In the ethical consideration, so most of your study subjects are going to be minors, yeah. So they are going to be less than 80 and so on. So you should have that in mind, and you should mention something how you are going to deal with that. Okay, you can read the different ethical manuals, national ethics guideline, and so on, and you can mention it. Just you have thought, okay, are you going to consider them as mature or considering, and are you going to to manage that is something you need to put. So what kind of consent are you going to take? Is it just a written or a verbal? It looks like a verbal form because there is no signature place in the consent form and so on. So I think why is that? Okay, because you are getting the woman, you are going to interview them. They are with you, so you can take a verbal, a written consent. Okay. So that's one thing. In the information sheet and form, you need to translate it into local language because IRB for ethical clearance needs that. And that's because they want to see whether the language used in the local language, whether it is understandable for various level of educationally for various level of individual study participants. Okay, is it properly translated from what is going to be reported, or in English, is it similar with the local language translation and so on, or something which is reviewed by the ethics committee. So you should have that translated information sheet and consent form in the protocol, which is not attached now. But one general comment before I finish I have is it would have been for me better if you make it some sort of a comparative study of the neonatal outcome between those with teenage pregnancy and with their adult counterparts. It will make it a sort of retrospective cohort. Okay, even if the observation time is very short, those with teenage pregnancy, you can consider them as exposed. And if you have adult pregnant woman, you can match with some very important variables, if you like. But for example, during the day of the delivery of a woman with a teenage girl, if you can take the next or an adult woman who have delivered the same day with some selected variable matching, you can show, and if you show if there is a difference in the neonatal outcome between the two, you can show specifically, that if the effect size of that difference, it's known that it's a well-established fact that they have more adverse outcomes. But in our population where there are additional factors like nutritional or in other factors, okay, that difference, how big is it? Is it similar with other studies, or it might be different in our population? It's something which you might show and might be more of a more interesting study for me, I think. This one, you may determine that, the prevalence of preterm births is X%, low birth weight is Y%, and so on. And you may compare it, service might be similar, then you'll stop there. But some sort of with minor modifications is favorable for such kind of modification and to be a bit more advanced study. So I would suggest if you have the time and to do that, and we can support you in that if you have the time to, or if you are allowed to do that now. So these are my comments. Thank you very much.
Thank you very much, Professor Delayo. It was very well reviewed, and I am sure Dr. Dansure and everyone has learned a lot. The advantage of being a researcher and a clinician is this: you can review the article from both the clinical perspective and from the research aspect, and it will give you a unique advantage when it comes to healthcare research. So the whole point of the platform is also to motivate clinicians to learn about basics of research so that they can apply it properly. So again, thank you very much for attending the session, Professor Delayo. I have very few things to add because I share everything that you mentioned, and I only have a few things. So Dr. Dansri, please share the slide so that the audience can follow. To start with the minor comment, when you state your objectives, your specific objective, for the first one, you have said that you stated it as to assess neonatal outcomes of teenage pregnancy in selected hospitals. So a specific objective has to be SMART. So one of the things that make it SMART is the fact that it has to be measurable. So to show that we use strong action verbs, so we don't use vague verbs like assess. So we use those things only for stating our general objective or specific objective, especially when we're measuring our outcome. For the descriptive measure, we have to say either determine, estimate, measure, and other measurable verbs. And for the inferential objective, for the association part, we can use the word, the verb to identify. So that should be replaced. In addition to that, still again, saying neonatal outcomes is also again very vague. In general, your outcome, you have a lot of outcomes that you stated, but we're not sure if it is a good idea, especially given that this is a thesis research and you're practicing research, and how much comfortable are you dealing with all those outcomes is a question. So I personally prefer if you restrict it to one of the outcomes, maybe the final outcome with regard to mortality. And if you stated as to determine the prevalence of neonatal mortality among teenage pregnancy, that would be better. Now you're telling us you are measuring mortality and you want to determine its prevalence. That's one thing. So being specific is good. So please put it on the objective slide. So we don't use the verb to assess for stating our specific objective. And it's better to be clear. Please avoid that. On the study area, I had the same concern, why we're interested in only the administrative hospitals. But more than that, if we are studying the risk of teenage pregnancy, if these pregnancies are have other additional complications, and if they become a high-risk pregnancy, then where do we refer them? We refer them to a hospital where there is a fetal-maternal specialist. I don't believe the fetal-maternal specialists are available in the hospitals under the Addis Ababa city administration. I'm not sure about that, but to my knowledge, these are available at either the Grand-Bessa or St. Paul Hospital, maybe private hospitals. So your chances of picking cases with high-risk pregnancy will be very low. And it will decrease your chances of picking the true rate of complication. So I think to mix it, you can pick Grand-Bessa and St. Paul, and you can keep, I don't know, 3 or 4 of the Addis Ababa City Administration hospitals. And you can also add one very high flow private hospital, so that you can have like a true representative hospitals in Addis Ababa, considering a high-risk pregnancy. But I think your concern is with regard to ethical clearance. We have a very inconvenient ethical clearance system, as far as I know. You have to pick your ethical clearances from different institutions. The federal hospitals provide their own ethical clearance, so they have to be reviewed by each IRBs. When you go to the private, actually the private can be provided together with the other hospitals under the Addis Ababa Regional Health Bureau. So that issue is there. If it's because of that, it's understandable. Otherwise, you can consider adding the hospitals. With regard to the study design, I also share changing it into a different design so that you can improve your chances of picking the outcome, or even in terms of how many teenage pregnancies do we see? Do we have enough number? I'm not sure about that. If you have a prior information, not only on the flow of on the birth rate, but with regard to their age, if you have a clear information, that would be great. But if not, you can change it, especially in terms of the outcome. We can consider case control, because after all, if we're not going to get a lot of cases with a lot of mortality or other complications, preterm birth or low birth weight, it's better to use a case control design or even comparative cross-sectional design to see if being teenage is actually related to high risk neonatal outcomes compared to the adults. That would be better. And also all the designs Professor Delayu suggested can be considered. And when you say this, your population, on the source population, you say that your source population is all mothers who give birth in a hospital setup. So all mothers are not your source population. Your source population, yeah, it can't be all mothers. Your source population is all teenage mothers. That's your source population. You're not going to start with all the mothers in the hospital. You're going to start with the teenage mothers who are going to be in the hospital, who are on a follow-up in the hospital during your study period. From them, you'll pick the number of participants that you have calculated based on your eligibility criteria. So all mothers are not going to be your source population and are not going to be your target population also. We're talking about teenage mothers, and that should be corrected. And the other is, you say that all mothers who gave birth, including those who are referred from other hospitals and admitted in one of the wards pre or after delivery. If you're going to consider those who are admitted after delivery, how are you going to pick how are you going to have an information on their APGAR score? So you have to revise your eligibility criteria. So if you're comfortable in including participants who are admitted after they deliver in another institution or their home, then you won't be able to get the APGAR score and even maybe other things. So I think you have to revise it and restrict it to either labor that are attended within the institutions. So home delivery and other referrals should be excluded. And on the exclusion criteria, just to add a few things, I think this medical disorders, twin pregnancy are like by themselves, these are variables. If there's a teenage mother who was like twin pregnant, I think this can be used as a factor to see if there is going to be worse neonatal outcome or not by itself. Why are you interested in avoiding this? If there is a medical condition, again, it should be included. Actually, you have also included it on your variable list and also on the questionnaire. So I think it's better to consider them as variable and remove them from here. And the other is, you said incomplete charts. This is a primary data collection. You have access to their charts and to the mothers at the same time. So if some things are not recorded on the charts, you'll have access to ask the mothers other than, I mean, some objective data that are to be measured. I'm sure if it is a hospital delivery, you'll get APGAR score, the birth weight, and other important variables. And I don't think incomplete chart will be a big problem, and that will lead you into excluding the participant. So that should be removed. And those mothers who are severely ill and unable to communicate will be excluded. But I think if you're looking for neonatal outcomes, if the mother is severely ill and to the level that she's not able to communicate, then this parallels, her condition parallels with a potential adverse neonatal outcome. So excluding these mothers will again cost you something, cost you your probability of picking adverse neonatal outcomes. So instead, you'd rather I don't know, take the history from a proxy, or since you're going to use charts, I'm sure most of the information will be obtained from the chart. So you can take an information from a proxy or after she's stabilized, because this can be directly related to a potential adverse neonatal outcome and something that you want to pick. With regard to the variables, I think there's a lot of confusion here. Your outcome or dependent variable has to be specified. I mean, if you're interested in studying about all potential neonatal outcomes, like whether they're alive or dead, their gestational age, birth weight, APGAR score, and even on the what do you call it, the conceptual framework, you have added infection and congenital malformation. These are a lot of things, and my personal suggestion is stick to just one outcome and focus on that and do your research. And you can collect data on the others, but you can, whenever you're comfortable, even after you work on your thesis, you can use the data to do further analysis. But at this stage, you are suggesting that you are going to have 4 different outcomes. And for 4 different outcomes, you'll be expected to do 4 different sample size calculation and 4 different analysis. So it's going to be very cumbersome. And instead of that, as Dr. Delayo also suggested, your chances of getting adequate number in all the outcome categories might be low. So you can either combine them as a composite score and use either adverse neonatal outcome or severe neonatal condition as an outcome. So that way you will have a better like proportion of outcomes, a compiled outcome, which will give you a good statistical result. So either use the composite outcomes as an outcome or just focus on one, either their gestational age or birth weight or whether they're alive or dead. And I think that's the best thing to do with independent variables, not only siblings who are sexually active, but also broken family. I personally don't see how it's directly going to be related to your outcome. And this is, I think, something that you have picked while you're reviewing literatures that might be considered as risk factors for teenage pregnancy. But further, when we try to see further beyond the teenage pregnancy risk factors, and when we try to apply it on the neonatal outcome, there is no direct link, and it's better to remove these things from the independent variable list and the questionnaire. And additional variables that I think you should consider are the nutritional status of the mother, and if she has any other previous pregnancy, it's better to take detailed information on that, whether there was complication, what was the outcome, and in the current pregnancy, if she has additional complications, and the mode of delivery, if there was any complication during labor should be picked, but it seems like most of the obstetric factors are just overlooked. And some other thing is there is a complete mismatch between your conceptual framework, variable list, and the questionnaire. These 3 things are very important whenever you construct your conceptual framework. If you have 10 independent variables, we expect to see those 10 independent variables on your variable list, and the same 10 independent variables are expected to be listed on your questionnaire. So if there is a mismatch between the 3 places, then it will be very difficult to catch up, and that it shouldn't be written that way. So you have to have equal number of variables on all the 3 places, and for all those variables, you are expected to have a question. But in your case, when we go to the conceptual framework, there is a surprise variable there. On the variable list, there is a different variable, and on the questionnaire, there is a completely different variable list, and most of your important variables are actually included there, but not on your included in the questionnaire, but not in your variable list in the conceptual framework. So try to match all the 3 areas. And with regard to the sample size calculation, if you take the comment of just restricting your outcome variable into just one variable, then the problem will be solved. If you don't, you are, as Dr. Delayo suggested, for each and every outcome, you should calculate a single population, for the descriptive objective, you should calculate single population proportion formula, the first sample size, and for the inferential objective, you have to calculate sample size using the double population proportion formula. So in every research, in any research where our interest is to look for associated factors, we have to use a formula which has power. That means there should be beta should be considered, the power of our study should be considered. So since single population proportion formula doesn't consider power in a cross-sectional study, we have to do an additional sample size calculation, which is the double population proportion formula. And finally, you have to pick the largest number. So you'll be expected to do a number of sample size calculations and finally pick the largest number. And with regard to finite population correction, we have a statistician attending the session, by the way, Mr. Deribsa. I'll give him a chance maybe at the end. So finite population correction, when your total population size is small, it's recommended to do that when it's less than 10,000. But if it is going to cost you by causing a very small sample size, that will lead you into a poor analysis result with wide confidence intervals, then we can drop it. Because when you drop it, the only thing is going to be you'll include larger number of participants. You will have a good data, a good number of sample size to calculate to do your regression analysis, and your chance of getting an acceptable, accurate result will increase. So the only cost will be on your part, on the data collection cost. Otherwise, it will improve the study. It will make it more accurate, credible. And I suggest to drop it because, 201 is very small, and adjusting it is not a good idea. And with regard to data analysis, once you set up your mind, you have to work on it again, because for the descriptive statistical procedures, what you have demonstrated is vague. You just say that frequency, percentiles, mean, and other things, but it's not clear which one are you going to use for which type of variables, and if mean or median is the most appropriate. You didn't tell us when are you going to use mean, when are you going to use median, and for which variables. Are there any assumptions that you like to test before choosing the test? That should be clearly put. And when we go to the regression analysis for the associated factors, you have to show us your regression plan for each and every outcome. Again, if you are planning to use all those outcomes, and we expect if there are 4 outcomes, you are expected to write 4 different regression analysis plan, because a regression analysis is run for one outcome at a time. So for each outcome, what kind of regression analysis are you going to use? And after you select the regression model, you have to show us what measure of association you are going to use, how are you going to test the assumptions of the model, and if finally your model is adequate, how are you going to check that? So you have to show that. And please avoid using the term multivariate, because what you are going to do is multivariable analysis, and there is a difference between them. And also avoid the term determinants, because for a cross-sectional study, determinants is a strong word. And due to the nature of the study design, we have to be conservative in stating our association. And the most conservative term is associated factors. So please stick to that and avoid using the term determinants. With regard to ethical clearance, in addition to obtaining assent, because they are minors, the ethical clearance process, you have actually corrected it on the on your slides, but on the original document, what you have stated is that Yekaitas Royal Hospital Medical College, IRB, will provide you with the ethical clearance that you can use for all hospitals. That's not the case. The structure is for hospitals that are under Addis Ababa Regional Health Bureau. The Health Bureau has its own IRB, and for government hospitals under the Regional Health Bureau, and for other private hospitals, the Addis Ababa Regional Health Bureau IRB is the one which is mandated to give ethical clearance. So the ethical clearance will be obtained from the Regional Health Bureau. I think this is something that's very important and that we all should not forget, because recently I have met few people who are working in a private hospital. They have a data, they want to use it, but they're not sure where to get the ethical clearance. So because of that, they have kept a very interesting data that should have been published on time for over a year. So for the regional, since they are under the Regional Health Bureau, the Regional Health Bureau IRB is the one who's mandated to give the ethical clearance for all of them. But if it is the federal one, all of the federal hospitals have their own IRB, and you should obtain the clearance from each hospital. So one final thing is, on your questionnaire, there is a place of birth as a question. If we can agree on the suggestion that I provided on the source population above and the eligibility, if you want to see including the Apgar score and other neonatal outcomes under the hospital's watch, then you have to restrict your eligibility criteria into those who delivered in the institution that you're going to study. if you're going to include home deliveries and other referrals, it would be difficult. And just one minor comment overall, your slide is a bit congested, especially if it is going to be presented for a larger audience in a big venue. It might be difficult to read each and every point, so it's better to make a revision on that. And this is all I have. Thank you very much. Mr. Deribsa, I'm not sure if he's Deribsa. Okay. I think he must have left the meeting. So with regard to the audience, Dr. Wandosan, can you please read questions and comments that are posted but are not addressed so far?
Thank you. So I think, can you hear me?
Yes, we can hear you.
Okay. Most questions are already answered, and one was asked by Mikhail, and it was answered through the inbox.
Okay.
But maybe to give a broader area of explanation, maybe you can help him with his question. He was asking for, is there any a standard way for selection of study areas?
I think selection of study area has to be made based on the title of the research, our research question. So if the cases that we want to study are more available in a hospital setup than a health center, then the choice is definitely hospital is a better choice. But if health center is a convenient setup, then it should be a health center. But if the participants are going to be available in both setups, then using a mix of all types of institutions is a good thing. I think Professor Delayo can help us here. Are high-risk pregnancy clinics available in all hospitals? I know you have one high-risk clinic at St. Paul. So does the regional health bureau hospitals have a high-risk clinic?
Yeah, I think most of them have.
Do they
The
have
problem here is for
maternal?
the teenage pregnancy, they may not always refer them unless they have even, I mean, at the health center level, unless they have additional abnormalities in pattern of labor or additional problems, they may not necessarily send them to a hospital. The actual practical thing we see on the ground is in the triaging, it's not given priority like let's say a woman having some medical comorbidity, diabetes and so on, definitely, or a scar and so on, they would immediately send them to the hospitals. But for the teenage pregnancies, especially those which are borderline, they kept on following them, so they don't have any problem. So that was one of my question earlier, and I think Dr. Dansuri answered that because